So good morning from New York and good morning on behalf of Inersis. Today we have a very interesting session, radiological intervention in hepatic malignancies. This will be delivered by Dr. Kevin Kim. Dr. Kim is a professor of diagnostic radiology and a nuclear medicine and a professor of oncology at the University of Maryland School of Medicine. He is a core member faculty of the University of Maryland, and the Stewart Greenbaum Comprehensive Cancer Center. His research focus is in the cancer therapeutic intervention, immuno-oncology, and interventional oncology. He has a background in interventional radiology and specific training in translational science and expertise in immunotherapy and interventional oncology, focusing in primary and metastatic liver cancers. As a PI and co-investigator, he led the building blocks for the liver cancer research by developing colorectal cancer and liver cancer in animal models, translational interventional oncology research platforms, and thermal ablation as immune modulators with immunotherapy. With that introduction, I will hand it over to Dr. Kevin Kim, who is going to deliver his talk right now. Dr. Kim, over to you, and please share your screen, and let's make sure that it all works well.
Good morning. Good morning. I'm so excited to be here. I'm honored to be here. And for the next hour and a half, we'll discuss what I'm passionate about, which is the liver cancer treatments. Let me share my screen. I hope that everybody can see the presentation mode of PowerPoint slide. So as it was introduced, my name is Kevin Kim. I've been doing liver cancer research for a couple decades. This is the more I do, the more I learn, the more intriguing and complex the disease itself it is, and that makes all of us challenged and stimulated to do more work on this. And I'm sure that everybody on this forum are sharing the same sentiment. So this is my disclosure for the last 5 years. What I was told is that I will do my lecture. It will be about an hour, and then we'll open up for discussion. I think that's the format that I was told. Let me start with the interventional oncology therapy. So the interventional oncology therapy is burgeoning, but yet quite busy. As you can see that these are a snapshot of current interventional treatments for cancer. The ones on the left-hand side are the ablative therapies. Many are very common. Many are upcoming. And the ones on the right-hand side are the transcatheter therapies, and the more to be coming. And I'll touch upon some of these today. Now, I was given a topic of a hepatic malignancy, which to me includes many different types of tumors, both benign and the malignant, especially in hepatology. I assume a lot of audience are hepatologists. You start with the HCC, hepatocellular carcinoma, and the cholangiocarcinoma. Those are the most common primary liver cancers, as well as mixed tumors. But there are lots of metastatic tumors. And then to me, neuroendocrine and carcinoid, the Mets are a little bit sort of a different group, which we dealt a lot. And then there are benign entities such as adenoma, the FNH, hemangioma, and the cyst. And all of these have a different treatment algorithm. For today, I'm going to mainly talk about HCC. I don't know how many interventional talks have been in this forum. I think I'm one of the early, maybe the first or one of the first. So I'll touch upon the HCC therapy today. Perhaps in some other forums, I can discuss specifically on other tumors, particularly cholangiocarcinoma, which is very intriguing. So this is the sequence of topics that we will discuss today: interventional oncology, immuno-oncology, interventional oncology and immuno-oncology, current studies and the future studies, and the prospect on HCC mainly. As a preamble, if you look at the survival curve of HCC, it hasn't really changed tremendously over the years for those of us who've been in the field for a while. And whichever studies, especially larger studies and the general studies, real life studies that you look at, this is a generalized survival curve that you would get. So transplant and the resection are at the top, followed by typically ablations, followed by transcatheter therapies, and then a little bit down the line, you would have other therapies, systemic therapy, radiation, and so on and so forth. And this has not changed substantially. But of course, there's a lot of new novel therapies coming, which are trying to change the trend. And I think this is a wonderful for our liver cancer patients. And these are some subgroups stuff. Now, the BCLC guideline, at least in the United States and the European countries, so we use this heavily, particularly at the transplant centers. And what's on the red box, those are the patients that we are mostly interested in, because these are the people that we believe that we can help, perhaps we can cure. And that's where the majority of resources on treatment as well as the research are going into. Now, HCC, just because it's got the same diagnosis name as most of us know, they come in all different shape, all different sizes, and the different characteristics. And those of us who've been doing this for a while, and I've been treating a patient with liver cancer for about 20 years, once you see the patient, both on the clinical side, laboratory, biological, as well as the imaging upfront, even before treatment gets started, you have a pretty good idea that that patient, whether or not that patient can be helped. So I'll just give us some generalized examples since as we are starting to talk. So a patient like this, a single tumor, 3-4 centimeter, well capsulated, this patient will get better by pretty much any therapy. Surgical therapy, if it is feasible, local regional therapy, systemic therapy. I mean, this patient will do pretty well based on what you see. Patient like this, which is a nicely circumscribed the tumor, however, has an extension of a tumor into the portal vein. So this is probably the PV1 or PV2. This patient, despite its advanced stage by BCLC, despite its portal vein invasion, technically, patient like this will do pretty well. As this is my patient, one of my patients, and he's doing well 4 or 5 years out, which is not supposed to be based on the BCLC criteria. Patient like this, very large tumor, right? Over 20 centimeter tumor, that seems daunting, but patient like this will do pretty well as this patient is doing. Now, patient like this, if you look at the imaging, there's sort of round tumors, maybe multifocal, maybe some in the portal vein, some in the lymph nodes. AFP is 9,000. But patients like this are treatable. Some of them do well, some of them may not. In this metastatic advanced stage HCC, that's how anecdotally we've been seeing. Some limited the lymphadenopathy doesn't preclude them from getting treatments. Now, we are getting into patients that are very, very difficult to treat. So a patient like this, diffuse infiltrated, albeit that there's no definite macrovascular invasion, no metastatic disease, or AFP is over 3,000, which is high, but not tremendously high. Patient like this typically do not do well, as was the fate for this patient. Patient like this, pretty cirrhotic, a lot of multifocal tumors, and the portal veins are pretty much filled up with the tumor, both in the right, left, as well as the main. So it's a BP4, PVT tumor. Albeit that there's no metastatic disease, patient like this typically do not do well, despite any heroic treatment. So as you can see, there are some sort of a generalized senses that the physicians or the providers typically get upfront. But nevertheless, let's talk about some treatments, what can be done for this wide spectrum of a disease of a patient. So first, I will start with the interventional oncology treatments. Now, for the last 3 decades, the interventional oncology treatments have changed drastically, largely because of image guidance advancement, like what you see here. This is a virtual guidance that a lot of people are working on now. So not only treatment have become more accurate and precise, but reduces quite a bit of complications. By and large, because it's image-guided therapies, we believe, and a lot of data have shown that interventional oncology treatments are effective, safe, quick, and cheap, so equals to better treatments. So this is a patient at the top pre-op and the bottom post-op on infiltrating PVT advanced stage patient that I treated a while back with the Y90 radioembolization. As you can see that the tumor has responded to the radiation Y90 radioembolization treatment enough such that after 2 years of careful watch, we actually transplanted this patient. So you can see that the advanced stage BCLC C PVT patient getting transplanted. It was before the IO time. So it was actually quite tremendous. So we learned a lot from this case that even advanced stage patient with the right kind of treatment, that the patient could potentially be saved and cured. This is a lung treatment, not liver, but the principles are similar. That very sick patient, DLC over 27%, our ablation therapies, which gets set up at 3 p.m. The probe advancement started about 3:50, and within half an hour, the treatment is done, and through a very small the incision site, right? So even in a very terrible lung patient or poor medical condition patients, interventional oncology treatment can be safe. As in this patient, this was a 94-year-old patient with a NASH and single solitary HCC. We did contemplate it and debated whether or not the local therapy could be safe and or, I don't know, quote unquote, indicated for this patient. We treated the patient local regionally. Patient did spectacularly well. As you can see on the poster picture, is a complete response, and the patient lived years afterwards with a tumor-free. So even such elderly patients, the treatment is safe, interventional oncology treatment that is. It's because it's quite effective at the precise focus, but it's got a limited collateral damage. So this is an explant study. You can see that where the treatment zones are, as opposed to the rest sparing of the parenchyma, whether it's on the lung, liver, same thing. It's quite minimally invasive. This patient had a spine treatment done by us, and then typically we just finish with the little Band-Aid. Outpatient discharged with a very little, if at all, recovery time. And even cosmesis is better, right? So this is a surgical scar for this patient. This patient was one of my patients, real story. And this is a laparoscopic scar. And our scar from our interventional treatment is hard to find, but these two are the scars from us. And so he's got all three of them. Of course, one on the right is major orthopedic surgery, and you can't even compare that with. Even the large tumors can be treated, as was done in this patient with the muscle, the metastatic patient treated with a cryo, as you can see. We do a lot of pain palliation nowadays. I mean, it's sort of a part of the realm of a liver cancer, but perhaps this is more for metastatic cancers. A lot of bone treatment, as you can see, and we started putting in these hardwares percutaneously without having to have a trip to the OR and stuff. These all gets done interventionally. So now, getting back to the liver cancer. So the major components of interventional treatments are planning. So planning needs to be done well based on all the pre-op data. And then the actual guidance, that's important, so that the treatment can be delivered precisely to the tumor. And then the effectiveness of the treatment, whatever the modality of a treatment it can be, which can be on its own or combined with other treatment strategies, such as IO, and I'll discuss that a little bit later. In addition to the conventional X-rays, CT, MRs, and so on, a lot of us are doing different things, 3D rendition, 3D recon, 3D printing models. All of these help to better plan the treatment, obviously for the benefit of the patient. The suites are important. This can be resource intensive, but yet some of the combined interventional suites, this is our suite, which combines, in this case, intravascular ultrasound, the cholangioscopic scoping, the CT, angio, fluoro, all of that combined suite, which gives our operators a full spectrum of guidance for accurate and safe treatment to result something like that. Now, a lot of us are employing the utilizing robotic guidance. It's still in infancy, but I'm pretty sure that in the next years to come, robotic guidance for interventional treatment will be probably the majority because the technology is getting advanced and through which it will be even more accurate and more precise for our patients. A lot of us are using virtual guidance now, this is so that we can add even more precision to our treatment in addition to our conventional image guidance. These are the sort of a view from your VR glass that you see. Obviously, this operator is trying to do the liver treatment. In addition to the sort of indirect image guidance, i.e. the MR, CT, and so on, we are also employing direct visualization. So this is the cholangioscopic view of the tumor, bronchoscopic view of the tumor as well. So all of those helps to better deliver better precise treatment for our patients. So for the liver cancer, as I alluded to earlier, that there's already a lot of treatment. You can see many plethora of treatments that we do, all the way from our conventional RFA, which is still being done at majority of the places, particularly in Asia, some European countries, even in the United States. Microwave ablation, which is now sort of a workhorse, at least in the United States. And then when I visited the Far East, China, Asia, China, Korea, and Japan is becoming much more common. Cryoablation, laser ablation, which have been very popular in Europe and also United States, have a role. The nanoknife or irreversible electroporation, monopolar pulse electric field ablation, which is a newer device, are very important in the treatment algorithm. And then also both thermal and non-thermal ultrasound-guided ablation, I'll touch upon on HIFU and the Histotripsy technology. On the transcatheter side, whether it's bland embolization, TACE, transarterial chemoembolization, drug-eluting chemoembolization, they are very common in pretty much all over the world, particularly for primary liver cancer. In fact, that's the sort of a gold standard on many countries. Also, hepatic artery infusion pump, Y90 radioembolization are becoming more popular. Immunoembolization is a sort of starting. And then on top of it, all the other ones that you can see on the bottom row as research treatments for now, intratumoral oncolytic viral therapies, intratumoral TILs, CAR-Ts, intraarterial therapies. All of these therapies are up and coming, and I'll touch upon a few of these. So for those of you who may not be familiar with interventional treatments, this is a cartoon that shows how the transarterial therapy gets done. So through a way, because a lot of particularly primary cancers are supplied by hepatic artery, not much of a portal vein. So we use that anatomical characteristics where such blood supply can be localized from hepatic artery, and whichever treatment medium, whether it's a Y90 radioembolization, whether it's a chemoembolization, whether it's a bland embolization, and so on and so forth, all of these materials gets infused and or administered directly to the tumor vascular bed. so that the tumor can respond. So this is a basically same concept pretty much on all of the transarterial therapy. Which is in case of a Y90 radioembolization, which is becoming more popular, is essentially internal radiation as opposed to external beam radiation. And by doing so, you can boost up and give tremendously high radiation, typically threefold or more as opposed to external beam radiation, so that the tumor can have significant effects, although the rest of the area do not get much of the effects. So that's the rationale of a Y90 radioembolization. Now, in contrast, the intratumoral therapies, which is becoming very, very widely used and very effective therapy, particularly as a definitive therapy, whether it's RFA, which was the first treatments that we started in the United States, or the microwave ablation. You target the tumor, whether by under ultrasound, CT, or MRI, and then you you advance this probe directly into the tumor, and then you activate the heat or energy, whether it's a heat, cold, electricity, directly to the tumor that is supplied by the antennas that you have. So this has been an incredibly effective treatment. Of course, all of these therapies are operator dependent, right? So operators' expertise, experience, all that comes in, just like any other surgical procedures. But by the right hands, meaning people with experience, these treatments have been tremendously successful. There's a cryotherapy, which we often do for kidney tumors and sarcomas and lungs and so on, but we also deploy this for liver cancer treatments. As you can see, that the ice ball that gets generated at the tip of the antenna basically kills the tissue. There are multiple effects that it delivers. It may also have a more immunological effects, which can be actually quite interesting. But nevertheless, this is a good tool to use for a lot of tumors. This is the cryotherapy for the liver tumor that we did. So far left is the pre, and this is the post in the middle. And then these are the follow-up. You can see that basically it leaves a small scar on a long-term follow-up under the effective measure. Now, these ablation therapies have been around for a long time. This is a EROTC study which sets this ablation therapy in liver tumor treatments sort of in a center stage. It was a while back, about 10 years ago study, but when this particular one was a colon cancer treatments, but when you put the chemotherapy plus ablation on appropriate patients up front, versus chemotherapy alone, as you can see that the overall survival and the progression-free survival of a patient who received the ablation in addition to systemic was much greater than those who didn't. So it became a standard of care amongst the patients who are eligible for this. And then this collision study just got presented in ASCO 2024 about 6 months ago from a Dutch group, where the colorectal liver mets patient were randomized to surgery or thermal ablation. Okay, for chemotherapy plus surgery versus chemotherapy plus ablation. And such a randomized study showed essentially no significant differences between people who got surgery versus a thermal ablation. In addition to chemotherapy, essentially you can see that the survival curve is flat. Therefore, the conclusion was that the resection for liver tumors in appropriate patients, small-sized tumors, were basically equivalent to that of the ablation. So if you look at the complication profile, it's understandably much better with the ablation, enough such that the study was stopped by the regulator at halftime and essentially no more patient that needs to be enrolled into this study, showing that ablation was equivalent to that of the resection. So I know it was for liver mets study, but by and large, a lot of things can be crossover. For HCC patients, the similar should be the case. Now, there's a lot of advancement with the scope studies as well. So a lot of ablation technologies are coming endoscopically, cholangioscopically, bronchoscopically, and I'm pretty sure that these will also change the paradigm of the treatment. Now, this is irreversible electroporation. You can see that these similar concept of delivering energy to the tumor, as you can see on the right, but particularly in tumors that are in close vicinity to, let's say, bile duct, portal vein, or hepatic vein, where it can cause either damage to the bile duct and or heat sink that we deliver. We use this device where the energy, electricity basically, shocks the cells. So it's not really a thermal energy, but it shocks the cell, and it causes a significant phagocytosis by apoptosis and causing cell membrane to break down and basically cell death. This was the earlier technology, so we have to use a multiple probes like this, and it has been actually quite effective. You can see that this tumor is smack right in the middle, which we treated it, and there's no biliary duct damage, and the patient got a good treatment. This is a newer technology. Pulse electric field is basically monopolar. The previous one was bipolar. This one is a monopolar IRE, which has actually is a new technology, and we are testing it. And this may potentially introduce more the treatment benefit for some of our patients. Now, this particular study, this particular device is supposed to also potentially have effects on tertiary lymphoid cell structures, which we are actually quite interested in from biological standpoint in HCC treatment. So potentially this could be an immunomodulation effects in addition to actual tumor kill. So we are looking at it quite carefully. This is one of my patients that we treated with the PEF, the monopolar ablation. Now, there are different technologies, but the similar things. So this is a HIFU or high-intensity focused ultrasound. Again, this is a thermal ultrasound, utilizing ultrasound to basically having oscillating the photons and the molecules to cause friction heat at the site. And you can see that there's a porcine liver, but that's the ablation mark that got done by this technology, which is available and is currently under a lot of studies. There is actually interesting technology, which is a histotripsy, which is a ultrasound-guided ablation, but this particular technology is a non-heat generated. And this is sort of how, and this has been actually quite of interest. There are more centers are getting this technology in the United States, and the data are maturing, but not yet out in a larger scale. So we will be highly anticipating to see how this essentially non-invasive technology can treat the liver cancer. Apart from it, on the drug aspect, there's a lot of different devices, right? So this is an intra-arterial drug delivery device, and there are multiple different types. Essentially, what this type of device does is mechanically, most often, but biomechanically causes more concentration of a drug, whatever the material that you're doing, to that particular tissue. So this particular device was created for pancreatic cancer and liver cancer, cholangiocarcinoma, which are currently being tested, and hope that there will be a good result from this. This is the percutaneous hepatic perfusion, the hemofiltration. And this has been around for some time for melanoma, but this is essentially getting isolating the blood supply of the liver, i.e. Cannulating hepatic artery and blocking the hepatic venous, so venous outflow. And then you bypass the blood coming from the venous circulation of the liver and you filter the blood that you just aspirated in the filtration, in this case, melphalan for melanoma, liver metastases. And then once you filter and aggregate the melphalan, you put that blood back into the liver. And then you have this constant circulation on this during this case. Pretty complex, pretty sort of involved. And this device, at least in the United States, was approved for the ocular melanoma patients, but the more studies are coming for other metastases in the liver as well as the primary liver cancer. So it will be quite interesting how the patients will benefit from this potentially. So as we've seen, what I've just shown you is a sort of a small snapshot of multiple different interventional oncologic treatments currently available and some in testing. There are more of these, and these are made for primarily primary tumors and the metastatic tumors. But oligometastatic oligoprogression is a very interesting concept and in actual clinical practice. And the immune modulation is of quite a bit of interest. So these are the different kind of tumors, both in the primary liver cancer, but also metastatic to the liver that we are working on. And so the field is incredibly wild. And also with the advent of a technical advancement and so on, essentially, we can put these drugs and so on to pretty much anywhere. As I'm working a lot more with the medical people, drug people, and so on, one of the first questions I've always gotten asked is, hey, can you put this into here and here? And basically, with the right kind of experience, interventional people, they can put these things anywhere in the body, even in the brain. So I think there's no limit on this as long as good drugs can be found to benefit our patient. So now let me briefly touch upon the immuno-oncology for HCC. I'm not going to dwell on this because I'm sure that you have had a lot of other speakers spoke on this. But immune therapy, even in GI cancer, has made a tremendous stride, right? So this was rectal cancer, stage 3 rectal cancer, got published in the New England Journal of Medicine on mismatch repair deficient patients. Immune therapy alone, no surgery, 100% CR. And that was tremendous, right? So even for liver cancers, I mean, there's a lot, right? So IMbrave 150, all of us are very familiar with. This is a atezolizumab study versus a sorafenib for advanced stage HCC. You can see the curve here, and there's a significant benefit of atezolizumab versus sorafenib. This is essentially a standard care for most of the patient now. Himalaya study, which is showing the improved survival on STRIDE regimen. That's a tremi plus durva. That's the durva plus one dose of tremi, that is, the outperforming the sorafenib. So you can see that this became standard care. And then the Nivo-EP study, again, compared to sorafenib, trumps the sorafenib survival. So again, this is a standard care. So there have been a significant improvement over TKI treatment with the IO, even in liver cancer population. So this has been tremendous for our patients. But there are, I shouldn't say thousands, but I know for a fact that hundreds of studies currently being conducted for the cancer vaccine, oncolytic viral therapies, and adaptive T-cell therapies for GI cancers. So this is a tremendously interesting field. So on one hand, we have a tremendously effective and safe the interventional oncology therapy. On one hand, we have ever advancing immune therapy. If you were to combine these treatments in some degree of a sequence, patient may potentially benefit further. So that's the concept of combining IO and IO. Now, if you think about this, there are essentially 4 different categories that you can think of. So the most common studies, as well as what we will see, are our conventional treatments, whether it's transcatheter therapy or ablation therapy, plus IO. And the studies are being conducted and some presented. And then the up and coming are the more novel, perhaps. So different cytokines, different the biospecific antibody therapies in combination with IO that's selectively given to the patient's tumor. Active immunization with the intratumoral cancer vaccine or oncologic viral therapies, and then also intratumoral activated T cell therapies. And all of these are currently being tested and formulated. So we hope that a lot of patients will get benefited in the future. Now, I should mention a little bit about oligometastatic disease. This is a concept that is essentially tremendously in other cancers, but even in a liver cancer, I think it's coming. So oligo concept is basically small number of tumors, metastatic albeit. If you were to treat those, then patient will get better. Now, this is not a new concept. It was been around for 20 years, but especially with the advent of immune therapy, this has come much more of an interesting and much more interest. So the goal is, for patients, even despite the metastatic disease, if local therapy for limited number of metastatic disease on top of systemic therapy can be delivered safely and less morbidly, whether by surgery, ablation, or whatnot, and effectively control the local disease of these mutated, perhaps, tumors, then potentially a patient may benefit by living longer. There are multiple different types of oligometastatic disease presentations. So this is a complex, and each one of these would have a different treatment algorithm, but this is sort of a holy grail. Once the primary tumor is controlled, if a metastatic disease are 5 or less, then local therapy, in addition to systemic therapy, can potentially cure the cancer. Now, this is sort of got bolstered, that this concept got bolstered by the genomic knowledge that, when you have a metastatic disease, whether it's a small numbers or large numbers, they are not all the same, right? So this is a sort of landmark New England Journal of Medicine article on the GU, kidney cancer, where over 60% of metastatic disease were not the same as primary cancer. So cancers are always evolving. Cancers are always mutating. So it's hard to imagine that one drug, whether it's IO, TKI, or anything else, can potentially work for all the cancers the person has in the body. In fact, this can be even more bolstered. That there's a study on the molecular cancer research showing that if you can detect one MET on imaging, typically it's 1 centimeter, then you would have already, over 1 billion circulating tumor cells. So you cannot believe that the over 1 billion cells would have exactly same genomic complement. And some of these may work with the drugs, and some of these may not work with the same drugs. Now, also, and this is this is a learning, but despite all the enthusiasm with the immune therapy, the people who are responding to immune therapy is actually minority. As you can see, melanoma has probably the best response rate, but it's about 40%, followed by lung cancer and GU cancer in solid tumor by about 25%. And you can see that all the other tumors, the response rates are pretty dismal with the immune therapy. I mean, we don't usually talk about it, but nevertheless, these are the facts. And then also, even the patients who primarily responded, many of them, unfortunately, do succumb to recurrences. So, immune therapy has been great, even for liver cancer, but they may not be the ultimate. So this oligometastatic disease, a study on liver cancer, this is a metastatic disease, but shows that in low the oligometastatic setting, having local therapy plus a systemic patients benefit from. And it's been already shown, even in a pancreatic study, and this just got published in 2024, that the patients with oligomets, local therapy plus systemic, which we never really did before, but patient benefit by doing local therapy. So there's a lot more coming. In the past, this is sort of what we used to think. Systemic therapy is good because it covers the cancer pretty well, and then the rest of the body, but there is some casualty, right? Because it affects the entire body. Tumor-targeted therapy is even better because it can affect the tumor more precisely, and perhaps it would have a less off-tumor target, but still they would have toxicity, and how much of drugs can go into the tumor. I mean, that's sort of it's up to debate. But intratumoral therapy that can get rid of all of these, right? Because you can put the drugs directly into the tumors and so on and so forth. The only thing is, used to be called, technically it may not be feasible, but now I think there's really no longer technical issue. So high local effects, high local concentration, low systemic toxicity. I mean, I think that there's a lot of things that can be done from interventional standpoint for these patients. So, the question is for these, and then there's a lot of these patients, right? The patient with the metastatic disease, when there is a resistant clones progress as oligometastatic disease, can local therapy consider treatment, considered a bona fide treatment line? I can tell you about 10 years ago, 20 years ago, for sure, even 10 years ago, this was sort of like a borderline kind of a thing. Now, I think that everybody recognizes it. What we don't want is this, but maybe we can do this. So this is actually the articles that I co-edited, I edited in Cancer Journal, which shows that this is actually quite bona fide treatment algorithm, even in a cancer crowd, oncology crowd. So I think there's a lot more to be coming. But oligometastatic disease is a spectrum of disease. This is not just technical, mechanical, but there's a lot more involved. So I think for especially young people who are aspiring scientists, this is a huge opportunity for research. All right, so the combination of interventional oncology and interventional immuno-oncology, I think this is to me most interesting because there's a lot of evidence, especially from basic science, laboratory science, translational science, that the local therapy can affect positively on the immune therapy. We've shown that, we've written actually quite extensively, and a lot of it is antigen presentation and its effects on the cytokines, and then its effects eventually on T cell function. And this can be done on a primary side, but also acquired resistance side. So this is our case of a cryotherapy on patient who develop acute acquired resistance. This was a lung cancer, but who responded without changing the same immune therapy. So this was actually pretty spectacular. This is a patient with the melanoma, liver mets, and the patients were basically progressing through and through on systemic. And without changing the systemic, we added it intra-arterial GM-CSF and IL-2. And you can see that not only liver lesions responded it, but also systemically, patient responded it as well. We've also shown abscopal effects with the Y90 radioembolization. But there are many things, ones on the right-hand side, that affects and can potentially affect positively as immune modulation. And not just the cold heat ablation, but radiation, GM-CSF, IL-2, all the cytokines and so on. And many of these are currently being tested. And then, of course, next, sort of a biggest thing is adaptive cell therapies, TCR therapy, TILS therapy, and the CAR-T therapies. They're all coming to solid tumor, including GI cancer and the liver cancer. So some of the trials, of course, there are thousands of these. So, but we'll just introduce some of these. So when it comes to this conventional stuff, ablation, TACE, Y90 plus immune therapy. There are many. Some are already presented. So this was the EMERALD-1 study, which was the immune therapy plus TACE versus TACE alone. And this study was presented and shown the improved with the immune therapy addition to TACE. There was an improved PFS, which was good. However, as a secondary, overall survival was not significantly different. This is a phase of 3 study of TACE plus lenvatinib versus lenvatinib, and you can see that there is improved on this study, a launch study, by doing lenvatinib with a TACE versus lenvatinib alone on overall survival and the PFS. But there are multiple studies out there with the TACE and the Y90. In fact, the MO3 study just finished enrollment, so that will be presented in the next couple of years, and that will be quite interesting. That's durva-tremi lenvatinib plus TACE versus TACE alone study. Now, and there's tons of other studies out there. Now, I didn't talk about the neoadjuvant or adjuvant study, but there's also quite a bit of interest on neoadjuvant and adjuvant studies. And just mainly to summarize, adjuvant studies, the data are coming. The current study, both the AstraZeneca as well as the genetic study shows better PFS, better recurrence, but the overall survival weren't impressive. So more data to be coming. Neoadjuvant studies, there's a very, very small pilot data, but it seems to show that there's a better necrosis rate, there's better pathologic response by adding IO up front before the surgery or ablation. However, overall outcome or the overall survival have not changed substantially. So, but it's the infancy data, and then the more to be coming. So those are all exciting field. So this article shows multiple different things that can be added to immune therapy, and these are local therapies to immunomodulate, and some of them I will show. So this is MO3 studies. I mean, this study finished enrollment. We were part of it, and this was actually quite exciting, and we're looking forward to seeing the result. And the cytokine and the biospecific antibodies are local therapy plus IO. There's lots of studies. This was one of them. This was a very novel, interesting recombinant, essentially clotting factor that the IA therapy for HCC. This is toll-like receptor 9 or TLR9 agonist, the infusion intraarterially directly to the tumor for HCC and the cholangiocarcinoma, in addition to IO for, and this is quite exciting novel concepts. Oncologic viral therapies also there's a lot. We are part of RP3, oncologic viral therapy for second-line HCC. There had been a lot of actually enthusiasm on oncologic viral therapy, showing a lot of responses on even very challenging patients. So we are quite enthusiastic. As one of the patients with the oncologic viral therapy as a research trial getting improved on. The transfer of activated cells or the adaptive cell therapy, I think is coming. These were the studies in the past, intra-arterial CA targeted therapy CAR T. And this is for the liver mets from colon cancer, pancreatic cancer study, intra-arterial for the liver. A lot of people are working on intra-arterial NK cell therapies. And, if you look at the timeline of the CAR T, I mean, it's a relatively recent improvement, recent events, mainly for hematological cancers and lymphoma, leukemia, is still pricey. I mean, you can see that the per dose is almost $500,000, but experts expect that this field is going to burgeon. The expectation is what used to be about $1 billion industry in the 2021. CAR T alone will be over $20 billion industry in 2030, which is barely next around the corner. So this is an incredibly exciting field. Not just CAR T, but also TCR therapies and TILS therapy. And there's now lots of interest on solid tumor, not just the hematological. But solid tumor has actually, particularly liver cancer, has even additive problem. So hematological CAR T is sort of somewhat straightforward, where IV infusion, it goes through the blood channels, and that's where the lymphoma leukemias are, and then they will get stored into your bone marrow. So it's a somewhat straightforward of delivery, aggregation, and there is a heck of a lot of environment that you have to deal with. Solid tumor is different, especially in the liver, where delivery of such from systemic circulation is a problem. And then once you deliver to the solid tumor, let's say in the liver, then it needs to be concentrated and aggregated in the liver tumor. That's a problem. And then also a lot of solid tumor, particularly liver tumor. There's a lot of chronic inflammation and a lot of microenvironment hostile, as you call it, that you have to deal with. All of which the hematological CAR T doesn't have to deal with. So this has been sort of preventing wild success on CAR T therapy for solid tumor just yet. But technologies are evolving and so on, and these are all coming to solid tumors. And also we are part of a moonshot study as well, which we are trying to look at and both the genomic and the immunological effects of all of these things with participating organizations. So these are the studies we have, and many others, of course, many other centers have, but we are big on the liver cancer research. So let me spend just a little bit, the final few minutes on how we take care of our patients. We are a big transplant center, big cancer center, and we pull our resources together. We have a multidisciplinary liver tumor board. It's a weekly. We usually talk about 15 to 20 patients each week. And that's attended by all the people that you see here. We have a lot of treatment, the modalities for liver cancer. Of course, some of them I already talked about on my talk, but there's multiple other things, so radiation, the surgery, and targeted therapies, and the trials. So these are resources gets pulled together to deliver care for our liver cancer patients. We also have a multidisciplinary on-site, same setting, the liver tumor clinic, which are attended by the people that you see there once a week. And we try to see as many new patients together here. It's a little bit of a time consuming and a little bit inefficient for doctors per se, but yet for patients, it offers a significant benefit of being able to see everybody and then get one concerted and the treatment planning at the end of the day before going home. And then we also have the liver cancer research lab meetings that we conduct. So the few things that are happening on our campus in terms of the basic science and the translational research. So Dr. Shetty's lab does a lot of biomarker studies on hepatocellular carcinoma and liver tumors. Dr. Meyer's lab does a lot of the environment studies as a transplant surgeon in terms of liver cancers. And the Dr. Ma's lab deals with the particularly genomic the components of liver cancer and the liver transplant to extrudate the data and the knowledge from particularly transplant patients. And my lab does the immune modulation work on the particularly pertaining to the local therapy. And Dr. Su's lab does a lot of microenvironment work, particularly for the liver cancer. And Dr. Ayatana Kovic's lab does the who leads our the cell therapy lab, the CAR T cell therapies for HCC. He actually has the fibrolamellar HCC, the CAR T cell therapy trial open now, but he's also quite interested in on non-fibrolamellar or regular hepatocellular carcinoma CAR T therapy. Amongst the studies he has done of interest, as you can see here, the blue line and the black line over here, the blue line are the systemic CAR T therapy. And then the red line, these are tumor sizes, the red line are the intra-arterial, intratumoral CAR T therapy. So you can see that there's a significant spread of doing CAR T therapy directly into the tumor HCC versus systemic. And I had talked about why CAR T therapy is difficult for solid tumor, particularly liver cancer. Perhaps this is a way, treatment strategy that we can circumvent such difficulty. So getting back to these are the patients that we want to save. These are the patients that we want to cure, and a tremendous amount of research and the clinical resources are putting into. I should end my talk saying that still the general data is dismal for liver cancer. Right here, where my red arrow is, this is the US data. This is the overall survival of a general population with the liver cancer. We are far behind that of other countries. The top is Taiwan, based on this study. This is Taiwan, this is Japan. I think this is South Korea and so on. So we are here, United States. Now, many factors, right? Because patients are different, diseases are different, etiology of a liver disease are different. And I got all of that. But still, having said that, the United States, with all the resources, all the things that we do, we are still far trailing back other countries. And if you look at down here, these are the treatment, these are the treatment modalities. The United States over here, in comparison, in this study, compared to Taiwan, South Korea, and Japan, we are doing far less definitive therapy, meaning Taiwan, South Korea, Japan, they do far more resection, local therapies, and so on, perhaps upfront or perhaps earlier stage patient, whatever the reasoning may be, but their outcomes are far better than that of the United States. So we should really think about it. And if you look at the studies, this is the one that we published, there's, in general, too many patients of ours are getting no HCC therapy. According to our study, 67% of a HCC diagnosed patient ended up not getting any therapy, either because they were diagnosed too late, or maybe they didn't have resources, they weren't advised correctly, whatever the reason may be. That's way too many patients, way too many United States patients not getting appropriate therapy. So that we need to work on it. So putting it all together as a summary, I think that immunotherapy, interventional oncology therapies are here to stay, and there's a tremendous potential to benefit our patient with liver cancer. I think adaptive cell therapy is also incredibly interesting for solid tumor liver cancer. I think it's coming, it's already here, and I think that we will get a lot more robust data out there. That we should pay attention to oligometastatic disease, even in the liver cancer patients, but there's a lot more things that we need to look into. So that's sort of the overlook of my view of liver cancer, and my view is coming from local regional treatment guy, and I'm looking forward to discussing with the audience and panel on anything that you want to talk about. Thank you.